Okay, so good morning. My name is Agata Kromer, and together with my colleague Kacper Zając, we have a great honor to welcome you to the Grand Prix scientific session.
We meet at the 11th edition of the Olymps. The previous editions gained interest among both medical and PhD students from Poland and abroad, with above 300 scientific works registered per conference. The main organizer of the conference is the Student Scientific Society at the Medical University of Lublin, an association of all members of student scientific associations.
Thank you very much for the presence of the session committee that will evaluate the presented works. We are very excited to welcome Professor Jacek Kurzepa, Professor Halina Lach, Professor Renata Hałas. We would like to sincerely thank all our partners to whom the 11th edition of the LIMS conference is truly an incredible event.
Before we start, I would like to briefly remind the rules of the presentation. The official language of the presentation is English. The presentations should last no longer than 7 minutes. There are 3 minutes designed for discussion. In case of exceeding the time by more than 7 minutes, the coordinator is privileged to finish the presentation. In this case, the discussion does not take place and the participant receives 0 points for discussion. One of the session coordinators will control the time and inform the participant when there is 1 minute left until the end of the time limit. The jury's assessments will include the following: the summary, relevance of the topic, the use of research in practice, the diligence of presentation, language of presentation, time limit, and discussion.
If any of the organizational issues are unclear, feel free to ask now. And if there are none, I am honored to open the Grand Prix scientific session of 11th Lublin International Medical Congress. The first work of our session is entitled Anti-Tumor Effects of Hemotonin on Human Melanoma, Induction of Apoptosis and Inhibition of Cell Proliferation in A375 cells, and it will be presented by Mrs. Laura Jonderko. Laura, can you hear us?
Hi, good morning. Can you see me? I see that you can see me. Can
Yes.
you hear me?
Yes, we can hear you very well.
Okay, so I'm gonna upload the presentation.
Yeah, please share your screen with us.
Okay, can you see it?
Yes, now we can see it.
Okay.
So perfect. Welcome again, and you can start.
Okay, so can I start?
Yes.
Okay. So good morning once again to the conference committee and all the participants. My name is Laura Jonderko and I'm a pharmacy student. So let's begin. To start with melanoma. I know that it is a no term, so I will not devote much time to this. However, a very quick statistic to outline kind of the genesis of the research. So cancer, about 1 in 5 people will develop cancer during the lifetime, and 1 in 9 men and 1 in 12 women will die because of the cancer. And cancer deaths will reach 16.6 million worldwide. And when we're talking about Poland, in Poland, cases nearly doubled in 10 years. So I present you hetamin. Hetamin is a small molecule, is a natural molecule. It is derived from the Cataminium species fungi, and originally it was reported in 1944, and it was actually a mixture of antibiotics. Hetamin belonged to the class of epidithiodiketopiperazine. Luckily, we can short it to ETP, and it probably will not tell you much, but it has a diketoparazine core with an unusual disulfide bridge. And this is a unique structure because it is a key to interaction with transcription factors and hypoxia-related protein, and its sulfur growth drives redox activity. And there is a small part of me trying to contribute, because in this study, we just began exploring the ability of the ketamine on the growth of human melanoma. So how was it done? So the investigation was carried out utilizing the cell line A375, melanotic melanoma cell line, and it was derived from a 54-year-old female patient, and the ketamine was dissolved in Dulbeco-modified Eagle medium to prepare the stock solution, and then it was subsequently diluted. The cell viability was evaluated by assessing the mitochondrial activity through an assay, and cells were seated to the plate, and the viability was assessed based on the standard protocol, and the absorbance of each well was measured at 570 nanometers. Cell viability was always also assessed with the cell title glow, and this time we seated them on the opaque walled plate because of the luminescence, and after cell lysis on the shaker and 10 minutes of incubation to stabilize, the luminescence was recorded. The real-time glow annexin 5 apoptosis assay was employed to assess apoptosis cell death. A cell was seated in the white walled plates, and here we follow the protocol as the producent suggested. The luminescence and fluorescence was tracked for 24 hours using a multiple reader. And the result, the most important part, so we have the effects of ketamine treatment and concentration of 0, 5, 10, 25, 50, and 100, and we have 3 periods of time, and it was 24, 48, and 72. So you can clearly see the kind of pattern here. The pools are decreasing with the increasing concentration, and the same, as I called it a pattern, we can see here on the another assay result. It is with the same concentration and with the same period times. Obviously, there are some differences between pools, but the correlation between them stay the same. And there's kind of a graphic sum up of results of both the viability assays. On the here we have the MTT, here we have the cell title glow. And the important is that the ketamine strongly decreased the viability of melanoma in the concentration-dependent manner, and it was clearly to see in the polls before. But here as well, we can see that it is as well time-dependent matter. Here we have the graph represented the results of the apoptosis assay. So here the concentration was 10, 25, and 50. And in the initial phase, we can see the increase of luminescence here. And it indicates that the annexin 5 is binding to the exposed PS on the outer membrane. And this is the hallmark of apoptosis. So the conclusion, so we have the results that it is the fact that ketamine induced the cell proliferation and the induced apoptosis and melanoma cells. So some words of discussion, because okay, we know about increasing mitochondrial membrane permeability. Another major effect of ketamine might be its inhibition of HIF-1 alpha protein. Additionally, may enhance oxidative stress by increasing reactive oxygen species. Ketamine has the strong potential in melanoma treatment. Obviously, further research is crucial to explore the whole impact of it, but I think that we have to as well explore some kind of aspect of the ketamine effects on the normal cell as well. I think the key areas will be explore the combination therapy. Thank you for the attention, and I'm happy to answer some of your questions.
Thank you so much. And now it's time for questions.
Thank you very much for excellent presentation, and your English also better than mine, so forgive. Excellent. We understand your presentation, your study. I think one question, maybe not one, but the first question, how do you think, what is a weak point of this study? Because we know the benefits, but what is a weak point? What can you tell about it? Mm-hmm. The study is very good, but yeah. Try to check the weak point.
I started with doing the natural products because I think it's gonna be, it's not gonna be that bad for human cells, but at the same time, it's not gonna be it's not going to be the one aspect that can be used during the cancer. It's going to be for sure beneficial, as I said at the end, that I think of combination therapy, that sometimes when we have the immunotherapy, sometimes there is some kind of the cells. Like I'm thinking to.
I think that this is typical for all in vitro studies. So this is not a point of this study. In general, we cannot transfer the results to the clinical subjects. I think from the directly transfer. Just only this is the first step of the investigation. But I think that you check only one cell line, one melanoma cell line, without the physiological line. The comparison to the normal cells are essential for this study because you check that.
Yes. As I said, I wanted with my speech before, I wanted to say that I think that it's going to be beneficial with combination therapy, but I said that I want to try as well check the, for example, fibroblasts and see how it's affecting normal cells, and then we can choose the concentration to be kind of beneficial for normal cell. It's not going to be that harmful, but at the same time, it's going to do something to the cancer cells. So for sure, I did it on the last slide of the presentation, that it is crucial to check how is it going on the normal cells. And even if I was doing apoptosis, I was doing not the full concentration spectrum. I was not doing the 100 micromole to the apoptosis test, because I think it's gonna be too much. I want to focus right now to 25, 50, and I think it's gonna be beneficial for both ways to killing the cancer cells, but not be that harmful to the normal cells.
Thank you very much. I think the explanation is very good. So, thank you.
There are any other questions or comments?
No, I have no questions and no comments.
Thank you.
Okay.
So thank you very much once more.
Thank you so much.
And now I would like to ask Mr. Józef Balicki to present his work entitled Evaluation of in vitro cytotoxicity of selected essential oils.
Okay, so welcome. You can start.
Good morning. My name is Józef Balicki, and together with my team, we have prepared a work entitled Evaluation of in vitro cytotoxicity of selected essential oils. Essential oils can be created from different plants and their parts by using the methods of steam or hydrodistillation. These oils can be used in medicine, skincare, aromatherapy, and as insect repellents. During this presentation, we will focus on 4 essential oils: tea tree, lavender, pine, and clove essential oils. Aim of this study is to show the effects of essential oils on human cells. These are the preliminary tests that will be able to be used in antiviral screening as later. The test was conducted in vitro. We have used several cell line panels, including non-cancerous cells like Vero and Rho, and cancer-derived cells like FADU, RKO, and U2OS. The cells were incubated for 24 or 72 hours. Let's start with lavender essential oil. Here we have 2 curves of concentration dependence on cell viability after 24 and after 72 hours incubation. After 24 hours incubation, we see there was a lack of influence on almost all cell lines, excluding RKO line, which viability decreased to 75%. After 72 hours incubation, there was a minimal influence on all of the cell lines. The influence of tea tree essential oil was very similar, but after 24 hours, the cell lines Rho and RKO viability decreased to 75%. After 72 hours, there was the same effect as in the lavender essential oil. Here are some photos that were taken after 24 hours incubation. Despite the highest concentration of lavender or tea tree essential oils, there was a lack of influence on the viability of these cells. They looked like the control tests. Now the clove essential oil. Here we got two curves again, but we also counted CC50, which stands for 50% cytotoxic concentration. And thanks to that, we can see that there was a strong effect on all of the cell lines, including the normal Varroa line and other cancerous. There is a strong connection between the time of incubation and the cell viability. Longer the time of incubation, the stronger the mortality of the cells. Here are again some photos. We see the clear effect on the highest concentration on the Varroa, RKO, and U2OS lines. Now probably the most interesting oil, the pine oil. Here we can see the sharp differences. It means that the one concentration can be fatal for almost all cell lines. And as we see on the CC50 table, the pine oil affected all cell lines, but the most the normal Varroa line. Surprisingly, the raw line CC50 oscillates near 80 micrograms per milliliter, despite the time of incubation. Here we again have some photos. The highest concentration was fatal for all cell lines, and for 125 micrograms per milliliter Varroa and U2OS lines. The rest monolayers looked like the controls. As I mentioned before, we have performed antiviral screening using two viruses, herpes simplex virus and adenovirus 5. As we see on the virus control, the cells are merging, there are enclosures. We consider balloon cells and vacuolization. After we add lavender or tea tree oils, it seems that we can see the normal, correct cells. And that means that these oils have antiviral effect, and this means that the replication of the virus was blocked by these oils. But the scale of this effect has to be marked in the future tests. We also used acyclovir as antiviral control, and we also used clove and pine essential oils on this virus, and they had antiviral effect too, very similar to acyclovir. We also used adenovirus 5, but there was no such a spectacular effect for all of the oils, lavender, tea tree, and clove and pine essential oils. To conclude, tea tree essential oil and lavender showed no significant cytotoxic effect on the tested cell line panel. Pine and clove essential oils showed cytotoxic activity against all tested cell lines. Pine and clove did not show anti-cancer selectivity. And the essential oils show some antiviral activity, which will be investigated in our further studies. This is our bibliography. And thank you for your attention.
Thank you so much. It was a very beautiful presentation. And now, does the jury have any questions?
Yes, I have one question. What is your personal role in this study? What is your contribution, your personal contribution?
We did the tests, we did the examinations, the passaging of the cells, the incubation, etc. Then we made photos and we put them in the presentation. And after that, we have to do absorption, measuring, and doing photos of these monolayers.
Thank you. And why do you choose these two types of virus?
Because we had them in our laboratory. That's it.
Thank you.
Thank you very much.
Congratulations to your presentation. One more question. Okay. So, do you see possibility of use these essential oils in your practice
Yes, of
or
course.
in another product?
Yes, because when we will do more tests on these cells, viruses, etc., if we discover the exact scale of these effects, we can use these oils in the drugs, in the future drugs, in pharmacy, in medicine, to fight with viruses or cancer cells. But as we see, the cancer cells were quite strong against these essential oils.
So I recommend to try the mouth rinse with essential oils and try to this treatment or this effect on your mucosa.
Okay,
Thank you.
thank you very much.
Thank you so much.
Okay, so now the work entitled Evaluation of Anti-Cancer Properties of the New carbazide and derivatives will be presented by Mrs. Agnieszka Rola. Okay, so welcome, you can start.
Okay, thank you. Good morning. My name is Agnieszka Rola. I am a fifth-year student of pharmacy, and I would like to present you the latest research conducted at the Department of Toxicology, Medical University of Lublin, evaluation of anti-cancer properties of the new thiocyanate derivatives with my co-authors, Łucja Walczak and Mariola Herbert from the Department of Toxicology. Thiocyanate are organic compounds. Thiocyanate and their derivatives exhibit interesting biological properties. These structures have attracted the attention of researchers in the development of new compounds with anticonvulsant, antiviral, antibacterial, antifungal, antioxidant, and anti-cancer activity. Recent scientific studies indicate their wide significance as potential anti-proliferative drugs. This study aims to investigate the toxic properties and selectivity of the action of a new thiocyanate derivative called GH3 in relation to breast adenocarcinoma and prostatic adenocarcinoma. In this study, the GH3 compound was evaluated. Its FTIR spectrum and theoretical properties were characterized. In vitro studies were performed on the following tumor lines derived from breast adenocarcinoma MDA-MB 231, the breast adenocarcinoma MDA-MB 468, and prostate adenocarcinoma PC3 cell line. Embryonic kidney cell line HEK 293 was selected as physiological line. The entity assay was used to assess cell viability. The tested concentration rate was 500 micromole per milliliter to 1 micromole per milliliter. IC10, IC25, IC50, IC75, IC19 values and therapeutic index were calculated using a dose response curve. A statistical analysis was performed using one-way ANOVA Danes test. The GH3 compound is N4-methylthio-phenyl 2,2-thiophene 2-ill-acetylhydrazine carbothioamide. In this slide, you can see the formula of the tested thiocyanate entity reagent, cell culture bottle, and example of entity results. The photos show the morphology embryonic kidney cell line HEK MDA-293 and the breast adenocarcinoma cell line MDA-MB-231, the breast adenocarcinoma cell line MDA-MB-468, and the prostate adenocarcinoma cell line PC3. Results. The theoretical properties of the GH3 compound were done by ADMET Lab 3.0. On the slide you can see molecular weight, log P, TPSA, which are needed to calculate Lipinski rule, Pfizer rule, golden triangle, and GSK rule. All of these rules are satisfied, and this rule facilitates the design of drugs with the desired pharmacokinetics, and a molecule that meets all these rules has a chance of becoming a potential drug. However, plasma protein binding is over 90%, which means the GH3 compound has a low therapeutic index. Blood-brain barrier penetration is very low. Volume distribution is below the optimal value. CYP1A2 inhibitor, CYP2C19 inhibitor, CYP2C9 inhibitor have their values near 1 or exactly 1, which means the probability of being inhibitor. Values of CYP2DC6 inhibitor and CYP384 inhibitor are low, which means a low probability to being inhibitor. The GH3 compound has some toxicity properties. As you can see on the slide, the highest toxicity has JNOC toxicity, drug-induced neurotoxicity, skin sensitization, and respiratory. The lowest HEK 293 cytotoxicity, ototoxicity, and hematotoxicity. We performed such a theoretical analysis in order to check the potential properties of the molecule and show that GH3 HEK 293 line should not be toxic in the physiological line. So in the further part of our studies, we set out to confirm this in vitro studies. The GH3 compound was evaluated by characterizing of FTIR experimental spectrum. We performed an FTIR analysis and assigned spectral ranges to vibration. According to the theoretical properties, the compound should not show toxicity on the HEK 293 cell line. In the entity TSA in the HEK 293 line, a concentration of 1 micromole per milliliter was noted a non-significant cytotoxic effect, while a concentration of 10 significantly reduced viability by 19.24%. The GH3 compound significantly reduced viability in the concentration range of 25 to 500 micromole per milliliter compared to the control cells, in the concentration of 25 by 45.59, in the concentration of range of 50 to 500 by 43.93 to 75.1%. A significant cytotoxic effect of the GH3 compound was observed on the the highest concentration of 500 significantly reduced viability to 15.28, and the concentration of 1 was noted a non-significant cytotoxic effect. In the case of MDA-MB-231, a weaker cytotoxic effect was observed where concentration 1 to 25 was noted a non-significant. The highest concentration of 500 micromole per milliliter significantly reduced viability by 62.31%. Based on the obtained results, we calculated the IC values. We needed to evaluate effectiveness of the tested compound, and the compound GH3 showed selective activity against the breast adenocarcinoma MDA-MB 468. And we also calculated the therapeutic index, and MDA-MB 468 has the highest therapeutic index, and the PC3 the lowest. Conclusions, the GH3 compound shows selective activity against the breast adenocarcinoma cell line MDA-MB 468 due to the lowest IC50 and the highest IT. The compound GH3 has a low therapeutic index against the tested cancer lines. In the future, its effect against other lines could be evaluated. Theoretical properties of toxicity on the HEK 293 cell line were not confirmed, demonstrating the limitations of therapeutical methods. Thank you for your attention.
Thank you so much for your speech. Does any member of the scientific committee have any questions or comments?
Thank you for the presentation. It was excellent, really. Just only one question, because I didn't see, maybe there was on the slide on the presentation, what kind of methods did you use for the assessment of viability of these cells? MTT or?
We used MTT assay.
Okay.
After this MTT assay, I calculated all of this in statistical analysis.
Okay. One more question, because you come from the radiopharmacy unit, yeah? So radiopharmacy. Did you use radiochemicals, some radioactive chemicals? No, just only without the radiation.
Our supervisor is from the independent
Yes, I know, but because I thought that maybe you have a special suit and the protection to make an experiment, something with radio chemicals and what it was.
No. Professor Monika Pitucha created this compound and gave us this compound to test at the Department of Toxicology.
Okay. Thank you very much. I don't have any question. Thank you.
Thank you very much.
Any other comments? Thank you so much again.
Now we would like to invite the author of the paper titled Evaluation of the Diagnostic Value of the Basophil Activation Test, BAT, as a subsidiary tool of diagnosing and monitoring allergy to Hymenoptera venom. Welcome, Mrs. Sandra Murawska.
Okay, so we can start.
Hello, ladies and gentlemen. My name is Sandra Murawska, and I am a medical student at the Medical University of Białystok. And today I would like to present the results of our work about the diagnostic value of the basophil activation test as a tool in diagnosing and monitoring Hymenoptera venom allergy. Let me start with some introduction. Hymenoptera venom allergy is an e.g. hyperreactivity to composition of allergens occurring in bee and wasp venoms. Allergy affects up to 5% of general population and is one of the major causes of anaphylaxis. Importantly, venom-specific immunotherapy is the only disease-modifying and curative treatment. Basophils and mast cells plays a crucial role in allergic reactions. Therefore, the basophil activation test is received great attention in context of allergy. The basophil activation test is a flow cytometry assay that measures the basophil activity in response to specific allergen stimulation. Considering mentioned information, our study aimed to assess the possibility of the basophil activation test in assessing hyperreactivity in bee and wasp venom allergic patients. Our study group consisted of 22 bee and 27 wasp allergic patients. Peripheral blood samples were collected, and then we performed basophil activation test using flow cytometry based on the presence of CD63 and CD203C markers. And that brings me to my next point, the results. Firstly, we decided to compare the basophil activation between two groups, allergic patients and healthy individuals. And as we can see at these charts, allergic patients were characterized by significantly higher basophil activation status. In the next step, we assess the influence of specific allergen concentration on basophil activity. And interestingly, we observed inhibitory effect of high allergen concentration on basophil activation, whereas the lower concentration of allergen caused significantly higher basophil activation status. So we decided to check if our basophils were even fully functional. And to that purpose, we used FMLP, an antibody against EGE receptor. And as we can see at these charts, basophils were functional and they were fully responsiveness. So we asked ourselves what was responsible for that inhibitory effect of high concentration of allergen on basophil activity. And in the next step, we evaluated the influence of allergen concentration on basophil morphology. And as we can see, higher concentration of allergen was not associated with any changes in granularity or size of our basophils. Moreover, the absolute number of basophils remain similar after high allergen stimulation. Finally, we investigated the influence of concentration of specific allergen on basophil apoptotic processes. We observed any significance difference in apoptotic cell frequency or caspase-free expression of basophils of our immune cells. And this is why we can say that the apoptotic processes were not associated with that inhibitory effect on basophils activity. And to conclude, we demonstrated high effectiveness of basophil activation tests in diagnosing in confirmation of Hymenoptera venom allergy. Moreover, we observed concentration-dependent inhibitory effect of high concentration of specific allergen on basophil activity. However, further studies are necessary to determine the specific mechanism responsible for that effect. And that brings me to the end of my presentation. Thank you very much for your attention. And if you have any question, I'll be glad to answer them.
Thank you very much for the presentation, excellent presentation. If I see the bee, so I'm very happy because we conduct also the project with the bee venom. And one question, how did you get the bee venom? How did you obtain the bee venom? Just you bought from the company, or you?
So we have a specific kit for basophil activation test, Bochuman, it's for Switzerland. And in this kit, we have our substrates for that. And
okay, so the bee venom is inside
yes.
This kit, so it's unnecessary to buy the bee venom as a pure, not pure, but in general, a natural compound. Okay. I forgot what I... Next time. So thank you very much. Just I forgot. I have one more question, but I don't know. Okay, thank you very much.
Okay, thank you very much.
Okay, the work entitled Deaths in the Course of Lymphatic and Hemopoietic Proliferative Diseases, the Experience of One Cancer, will be presented by Mr. Karol Pigosiński. Welcome. Okay, so you can start.
Good morning, everyone. My name is Karol Bigosiński from the Medical University of Lublin, and with help of my co-authors and Professor Małgorzata Mitura-Lesiuk, I would like to present you an original paper titled Deaths on the Course of Lymphatic and Hematopoietic Proliferative Diseases, the Experience of one Center. As a short introduction, the proliferative diseases of lymphatic and hematopoietic systems are a very broad group of hematological disorders that are very significant cause of death among pediatric groups. They include leukemias, lymphomas, and myelodysplastic syndromes. And for leukemia, the mortality rate ranges from 1.3 to 6.3 per 100,000 in men and 1.1 to 3.8 per 100,000 in women. The overall 5-year survival rate for childhood ALL is about 90%, and for childhood AML is about 65 to 75%. Even higher rates are reported for Hodgkin disease. It's about 95%, and about 70 to 90% for non-Hodgkin disease. In contrast, the MDS diagnosis is associated with 5-year survival rates at 35 to 48%, and the mortality rate is estimated by 15% during the chemotherapy. The purpose of this study was to present the demographic and clinical characteristics of pediatric deaths of patients with lymphatic and hematopoietic proliferative disease from years 2008 to 2024. A database of 48 deceased patients of the Department of Pediatric Hematology, Oncology and Transplantology of Medical University of Lublin from years 2008 to 2024 due to proliferative diseases of lymphatic and hematopoietic system were collected. Selected demographic and laboratory variables were included, as well as the differences found between the groups. The MedCalc 15.8 software was used for statistical analysis, and the D'Agostino-Pearson test was used to analyze the normal distribution. The continuous variables were compared using student's test or Mann-Whitney U-test, and the categorical variables were compared using Pearson's chi-square test. The table on the slide shows the demographic and clinical characteristics of patients died due to protein cell diseases, whose more significant results I will discuss. The study group was 48 patients, and the median age of patients was 138 months. 37 cases were leukemias, which of 60% were ALL and 40% were AML. The next 7 cases were lymphomas, which of only 1 case was Hodgkin disease. And the last 4 cases were the other diagnoses, which of only 2 cases were myelodysplastic syndromes. The median time from diagnosis to death was 8 months, and talking about reason of death, 60% died due to progression of initial disease, 17% died due to treatment complications, and the rest of patients died due to other reasons. The next table to be analyzed will be the demographic and clinical characteristics of patients with leukemia diagnosis. And the median age of diagnosis of ALL patients was 142 months, while in AML patients 128 months. But the time from diagnosis to death differed significantly, being 11.5 months in median, 11.5 months in ALL patients and only 3 months in AML patients. But talking about laboratory tests, LDH activity was significantly higher in ALL patients. In median, it was 700 versus 500 for ALL. And the last table to be analyzed will be the comparison of demographic and clinical characteristics of patients with leukemia and lymphoma diagnosis. And the median time from diagnosis to death was slightly, but statistically significantly longer in leukemia patients. It was 8 versus 7 months in median, and the lymphocyte count was noticeably higher in leukemia patients. And talking about platelet count, it was significantly higher in lymphoma patients than in leukemia patients. And two conclusions of our work: proliferative diseases of the lymphatic and hematopoietic systems are very common cause of death among pediatric groups, and the different groups of patients differ in terms of demographic and laboratory parameters, which can significantly facilitate the determination of prognosis and selection of effective treatment. For my part, that's all. Thank you for your attention.
Thank you so much for your presentation. Does any member of the scientific committee have any questions or comments?
Yes, I have one question. First of all, I would like to congratulate your presentation.
Thank you so much.
The topic is also very interesting. You told us that the most common cause of death was progression of disease. What is the other causes of the death, because they were in chart?
Like I said, the progression was 60% of deaths. And the other 70% was treatment complications. And when I want to say something about treatment complications, half of
which complications?
Which complications?
Yeah.
Nearly half of the complications were infections, and about 30% it was aplasia or hemorrhagic complications. And the other reasons were not...
Hemorrhagic complications, it means bleeding from
yes,
alimentary
exactly.
tract, for example.
Yes, exactly, like bleeding. And it was about 10% of gastrointestinal complications during the treatment.
Thank you.
I would like to congratulate and underline how important topic you took for your research, because this kind of the study is very important to plan the next research, the next study, which was presented in previous presentation. So I congratulate you very much.
Thank you so much.
Choosing the topic.
Thank you.
Thank you.
Okay, so thank you again. If there are no comments left.
Now, I would like to ask Mrs. Aleksandra Opąchowska to present her work entitled Exploring the Importance of Peripheral Blood Monocyte Subpopulations in the Course of Treatment of Pediatric Patients with Type 1 Diabetes.
So you can start.
Ladies and gentlemen, esteemed committee, it's a pleasure for me to be here today. My name is Aleksandra Opąchowska, and I will be representing a student scientific group at the Department of Regenerative Medicine and Immune Regulation at the Medical University of Białystok. Today, we will be exploring the importance of peripheral blood monocyte subpopulations in the course of the treatment during the pediatric type 1 diabetes. Type 1 diabetes accounts for approximately 10% of all diabetic cases, and it is usually diagnosed in the ER setting due to the sudden onset of the ketogenic acidosis, and it is associated with the autoimmune destruction of the beta cells of the pancreas, and therefore these patients cannot no longer synthesize their own endogenous insulin, and therefore they need daily insulin injections. Typically, in the human body, we can distinguish three main populations of the monocytes, namely the classical, the intermediate, and non-classical ones, and they perform varied roles. They perform varied tests in the human body. Classical monocytes are usually the ones to be the first at the site of the bacterial inflammation. The intermediate monocytes are associated with the antigen presentation process, and also the non-classical monocytes are seen mainly as regulatory cells rather than infections or response-associated ones. In other autoinflammatory diseases, such as rheumatoid arthritis or the systemic erythematosus lupus, Especially the intermediate monocytes were seen to contribute to the orchestration of the autoimmune process and also the driving the autoimmune process. Therefore, in our study, we aim to evaluate the monocyte subsets in newly diagnosed type 1 pediatric patients during the course of their treatment. Our study comprised 51 newly diagnosed pediatric diabetic patients and also 31 healthy controls. The peripheral blood was taken and the cell frequencies, the monocyte cell frequencies were assessed through the flow cytometry. We also intended to measure the clinical parameters, especially the glucose level, the glycemia, the levels of autoantibodies directed against the pancreatic tissue, and most importantly, we wanted to measure the C-peptide level, which is a marker for the endogenous insulin synthesis in the human body. This brings me on to the results section. We discovered that in case of the intermediate monocytes, their level was significantly elevated in the pediatric patients when compared to healthy control, while the remaining subtypes, the classical and non-classical monocytes, did not differ statistically between the pediatric group of pediatric diabetes and healthy controls. We also wanted to evaluate the association between the autoantibodies level and the clinical parameters and the other frequencies of the monocytes, and we discovered that initially higher level of the GADA autoantibodies were associated with an increased percentages of the intermediate and non-classical monocytes in diabetic patients. Moreover, other clinical parameters seem to be relevant because higher initial admission time, higher baseline level of the glycated hemoglobin was associated with lower levels of non-classical monocytes in the peripheral blood, while higher glucose levels were associated with elevated frequencies of classical monocytes detected in those patients. We also wanted to kind of assess the level of C-peptide level during the therapy, because as I said before, the C-peptide level is a marker for the endogenous insulin synthesis. Therefore, increase in C-peptide during the therapy can be seen as a therapeutic success. And we discovered that higher levels of intermediate monocytes at the admission time were later associated with a higher level of C-peptide and also a higher percentage of classical monocytes at the admission time at the beginning of the treatment were later associated with the decline in the C-peptide level after 2 years of usual standard regimen diabetic therapy, so the insulin injections in case of the type 1 diabetes. Finally, we aim to assess the risk ratio for the maintaining of the clinical parameters within the optimal levels. And especially C-peptide is important here. We discovered that monocyte levels influence and have relationships with the chances of maintaining the C-peptide level at the optimal level during the therapy. And we discovered that lower percentages of classical and non-classical monocytes at the admission time were later associated with a lower chance of achieving an optimal level of C-peptide after 2 years of the therapy. What should be our take-home message from this study? First, we discovered that monocyte subsets in the peripheral blood can be associated with the rate of the progression of the type 1 diabetes in the pediatric patients. And moreover, they have relationships with the clinically relevant parameters that are assessed at the moment of diagnosis. So the autoantibodies or glycemia level or the C-peptide level. Here we should also mention that, which may be surprising, the intermediate monocytes may seem to have beneficial role in case of the maintenance of the optimal C-peptide level. But in the future studies, we should focus at the determination if the monocyte levels can serve as a potential biomarkers for determining the dynamic of the development of type 1 diabetes and also for the effectiveness of the treatment. Thank you for your attention.
Thank you for your speech. And now, does any member of the scientific committee have any questions?
You included 51 patients.
Yes.
How long do you collected these patients?
It was actually not a very long time because we acted in a cooperation with the pediatric clinic. With the
And you
professor.
take them from database of?
No, these were the patients that were admitted to our ER at the pediatric university hospital, and later, after a few days of the metabolic normalization, because they were suffering from the ketoacidosis, they were included in a study. I believe that those 51 patients were taken in a few months, I believe. It was done like a year or two ago.
Thank you.
Okay, I think that's all.
Not yet.
Not yet? Okay, sorry.
Congratulations to the very nice presentation. And just a question, do you see any another biomarkers for monitoring the diabetes 1-1 diagnosis and treatment?
In our piece of the study, because this is only a fragment for a bigger study that we conducted, we also evaluated the lymphocyte levels. And in lymphocyte levels, we also discovered some interesting parameters in association with the C-peptide level and other clinical parameters. So it's like this is only a piece of the cake for us. And maybe in the future, we can say more about the correlations between lymphocytes, monocytes, also maybe neutrophils.
So it looks like a nice cake. Congratulations.
Thank you.
Okay, thank you so much. And now the next person.
Mrs. Cornelia Polat prepared work entitled Parental Satisfaction and Health-Related Quality of Life in Children with Fragile X Syndrome. Welcome. And you can start.
Hello everyone, dear esteemed jury, dear audience members. My name is Cornelia. I'm a fifth-year medical student, and I will present parental satisfaction and health-related quality of life of children with Fragile X syndrome. Fragile X syndrome is caused by the trinucleotide repeat expansion on FMR1 gene, and that leads to hypermethylation and an inactive gene, so the lack of FMR protein. By definition, it is a rare disease affecting 1 in 8,000 females, while only 50% show symptoms, and 1 in 4,000 males, while all males show symptoms like intellectual disability, characteristic dysmorphic features, and macroorchidism. Our study aimed to evaluate the current status of parental satisfaction and health-related quality of life, to identify the perceived gaps and barriers, and finally develop directives for a multidisciplinary care program for affected. So we did this by conducting a survey. It was mostly comprised of original questions, but we also added the assessment tool KidScreen 10, and we distributed it thanks to the Fundacja Rodzina X, which is a patient organization. Our cohort represents the general population well, with the intellectual disability, the age and gender. So the main question, are parents satisfied with the medical care their children are receiving? The answer is no. So what challenges do they face? It is lack of sufficient knowledge among doctors, lack about the syndrome, lack of general information, and limited access to specialists. So I divided the group into 2 parts, which is those without a specialist center and those with. And here we see differences in numbers that are the current specialists that they're under the care of, the amount of specialists they would be more under the care of, as well as the medical visits they have during 1 year and hours spent commuting to those visits. So taking into consideration the communication, they are also dissatisfied with the exchange of information among specialists. Even though they evaluate their communication with the medical staff better on things that they are most concerned about, like symptoms connected to the intellectual disability. They still reach to sources like scientific articles or, on the second place, social media. So what is their perceived knowledge level? They feel well informed about genetic background, symptoms, and diagnosis, but they are lacking information on emotional, psychological support and long-term medical care plan, which we will look into further. So when it comes to the long-term medical care plan, the future, it is connected with general anxiety, but also inability to ensure proper care after parents' death, which is connected to the current state, and that is that the disease affects the formation of relationships and also causes the daily life functioning to be difficult. So what emotional support they are getting, the parents are very dissatisfied with it. However, they do think that their children are getting the emotional support, just not from external resources, and it being mostly mothers and fathers. So, taking all of those things into consideration, we would think that the health-related quality of life that the parents would evaluate for their children is bad. However, compared to the national norm data, it is actually above the 50th percentile. Does this mean that a multidisciplinary care plan is not necessary? In my opinion, it does not. So we've asked them what are their expectations towards one, and this summarizes our findings well, because it is integrated care at one place at one time with the same specialists yearly, and also directives for treatment, and followed by financial and psychological support. So this is exactly what we did at the University Clinical Center at the Department of Rare Diseases. Until now, 11 patients were admitted, and they are under the care of 8 specialists combined with further examinations. So our future objectives are to evaluate the satisfaction once more, and also possibly use other health-related quality of life assessment tools, and also develop reliable sources of information and provide support for adults and the transitioning zone. So these are my resources, and thank you very much for your attention.
Thank you. Does anyone have some questions or comments?
I have 2 comments.
Yes.
Okay. So 3 comments. First is congratulations to your very interesting study, and there are so many data you presented to us, so I would like you to encourage to write a paper.
Oh, thank you.
This is very interesting and many information for us and for the future readers.
Thank you.
And also I noticed that in a group of specialists I didn't notice a dentist. It's also very important because you mentioned there are some problems in the oral cavity and dental problems with this group of children. So also think about this and talk with your supervisor.
Definitely. Thank you.
Thank you.
Okay, any other questions or comments? Okay.
Thank you very much.
Thank you again. So it was the last work to be presented in this session. We would like to thank every active participant and the members of the scientific committee. I am very pleased that we collected so many interesting presentations, and I am very glad to our scientific committee for such many questions or comments from which we can all learn. So yeah, thank you again.
Now the jury will sum up their marks. Please stay nearby the room as the results will be announced.
The jury will sum up their marks, and the results will be announced at the awards ceremony today, later.
Now we encourage you to take part in the Inspiration Zone and other lectures. We hope to reach you at the next edition of our event, to which we are now warmly inviting you.
Goodbye, and we wish you all the best. Thank you so much.
Thank you so much.
So, good morning, everyone. I have a great pleasure to invite you to today's lecture. And it will be personalized treatment, 3D printing, and AI in medicine. Please welcome Assistant Professor Grzegorz Staśkiewicz.
Okay, good morning, ladies and gentlemen. Great pleasure to be invited by the organizing committee to have this lecture. And two topics that are related with the most recent breakthroughs in medicine, or the beginning of the breakthroughs, at least in the case of artificial intelligence. So I hope you will find the lecture interesting. So I'd like to focus on these two technologies. So 3D printing, which has a relatively recognized position in the medicine already, and artificial intelligence, which actually does have the several recognized applications. At the same time, frankly speaking, we actually cannot predict what will it look like in few months or few years, not to mention the longer period. So we could ask a question for the beginning. Are the new technologies friends or foes? Obviously, speaking of medical applications of technologies, we should first look at the patient's perspective, at the improvement of the patient outcomes, at the improvement, at the better utilization of the resources that will always be limited. No matter what healthcare system it will be functioning within, there is no healthcare system that would allow you to do everything you want. This is what I believe is one of the key applications for both these technologies, so that to improve the utilization of the resources that we have, that are and always be limited. At the same time, introduction of new technologies will always change the status of what the daily workload looks like, what the patient care will look like, what is the patient's perspective, what is the patient's cooperation with you as the physician. So it also changes what are the main interests in particular specialty. And it does change, and it will always change whenever new technologies have the introduction to particular specialty. In particular, in case of artificial intelligence, I would like to show that actually there is no single medical specialty that would not be affected by these solutions. And this is what is happening right now. So I would like to start with the rapid prototyping. What is this technology, and what are the possible applications? At first, I would like to introduce you some technical details on what this rapid prototyping is about, because even the term rapid prototyping may be sort of confusing. Because rapid prototyping, when you look at some videos, how some 3D models are printed in the modern 3D printers, most of these videos are accelerated several times so that to speed up the rate of this presentation. However, this word rapid here, we should rather consider to be, well, sort of rapid, because the term was coined as the opposition to the traditional process of preparing the objects for the industry. So whenever the prototype had to be produced, no matter whether it was some, car part or some new tool, the whole process from the designing the object to getting the physical object produced took a long time, lots of resources, because one had to design all the process, design the supply of the materials, design what tools will be used for this process, and then start this production of the prototypes, then check what the process looks like, how to improve it, what fine-tuning should be introduced so that to improve the workflow, the time required, the resources required, and all that takes simply time, lots of calculations, lots of effort for that. So rapid prototyping, as opposed to this traditional prototyping, means that this technology allows for significant shortening of this time. This is important because for the orthopedic surgeons, when they realized that they could use the 3D printed models for like the sort of preliminary, like the mock reconstruction of the broken bones, for example, they must realize that it's not like the patient has a CT scan and right after the patient leaves the room, you get the 3D printed object. No, it has to be still extracted from the DICOM data from the CT study. It has to be manipulated so that to improve its quality, so that to then design its printing and then print the actual model. Altogether, it takes, hours. Yeah? It's still rapid as compared with the traditional prototyping processes, but one has to be aware this is not something that happens instantly. So the whole rapid prototyping thing began in the 1970s in the United States with the procedure that is now one of the methods of rapid prototyping that is called selective laser sintering, developed by Carl Decker, who is on the photo on the left. And at the moment, this is just one of the modalities that we have available for rapid prototyping, but it used to be the first one. And let's have a look at some examples of what techniques we have available. So one of the earliest, except for the selective laser sintering, is stereolithography. Those who are familiar with the 3D printing, at least even in some basic aspects, you know that the file format that is used for the designing and the printing of 3D models is actually STL format, which stands for stereolithography, because this was the first modality where this file format was introduced. And the STL files, they store the instruction for the model, which does not contain any information about the color. It contains the measurements, which are expressed in the three-dimensional scale on the as the points for the triangles that make up the mesh of the actual object. So stereolithography used to be the first widely used method, which is still in use and has some great advantages that I would like to mention. But what does it look like? Stereolithography uses the laser beam and uses a photopolymer, which is liquid. And the thin layer of this photopolymer is hardened with the laser beam, which layer by layer will build up the model. What will be the benefits of this technique? First of all, the resolution. Those who are familiar with 3D printing know that those cheapest 3D printers nowadays, they produce the models that are really, really clearly layered. Yeah? With stereolithography, you may get the small models usually, but with very high resolution, very fine details. That's why stereolithography is, for example, in wide use in dentistry, for designing like the single teeth replacement molds and so on. But in wider aspects, it's, for example, it's widely used in jewelry making. It may be used with very fine details being produced for the models, which then may be produced out of metal like silver or gold. So stereolithography will have main aspect will be its very good resolution. Limitation will be, of course, the materials. because the material that is used is this photopolymer resin, and all the materials, so all the objects that you get produced with this technology will be transparent or semi-transparent. This is what this technique looks like because of this laser beam hardening. It must be at least semi-transparent. But the resolution here is the great benefit. Next technique would be selective laser sintering, and this is this first technique that has been introduced in California in 1970s. Again, laser, but this time, as you see, there is a build chamber which is filled with layers of powder. And this powder is being hardened by sort of melting the single layer, and layer by layer, this powder is melted, and as it hardens, you get the solid object, which has been sort of fused powder particles thanks to the use of laser. Limitations of the technique would be the limited range of materials that may be used, because these are usually like metal-like materials. But physical properties are very good, and it remains one of the main modalities that are in wide use in industry, like car industry, for example. This is commonly used one. Then time for the technique, which is quite widely recognized by everyone who thinks, well, 3D printing. You think most usually about the FDM technique, which is a fused deposition modeling. What does it look like? We have the filament, so the thread that is semi-elastic, sort of like plastic wire, and there is the extruder, which melts this wire and feeds this melted plastic on the bed of the printer, which moves downwards, and then layer by layer this object is being produced. Benefits? Well, first of all, availability. Yeah? Although 3D printing, the actual term refers to another modality which I will introduce in a second, then actually the FDM method and 3D printing became almost synonymous nowadays. Although technically speaking it is not 3D printing, but FDM, which is nowadays the most widely used modality, mostly because of the relatively cheap equipment. Wide society of users who do lots of improvements in those printers. So this is most widely available low-cost method, which allows sort of like entry into the 3D printing or rapid prototyping for everyday basis. Originally, the materials that were used were quite limited to this plastic. PLA is widely used method, which is the polylactate. So it contains the organic compounds with relatively low melting temperature. But lots of other materials are in use. For example, if it's mixed with the tiny pieces of wood particles, it may produce sort of wooden objects or wood-like objects. For example, there may be some metallic particles also mixed. There are special filaments that conduct electricity, for example, and other applications here are available. Of course, lots of colors, lots of transparent, non-transparent filaments. However, the range of colors is limited. Most of the printers allow for only one type of filament to be used for one print, because the second spool here is for the support material, because producing the object layer by layer, if it's complex shape, you need some support for your object, which then must be removed. So even by designing the printing process, you must take into consideration that this sort of bottom surface of the object will be not as even as you would probably expect it to be. So even this should be taken into consideration. However, speaking of those different types of materials, you could, well, scale up this printer even into this scale, because as you see, actually, there's this exact same printer concept as on the previous slide, just used for the printing with concrete. And you see, again, layer by layer, you may notice how this building is being produced within days instead of months. And last but not least, the actual 3D printing, which uses the little of the concept of selective laser sintering, because we also have the powder filled chamber, so you don't need the support material then. But the hardening of this powder, layer by layer, is produced by the sort of inkjet similar to the ink printer. There is a sprint head which sprays the substance that will harden specific areas on this specific layer, and then another layer is being added. So this is actual 3D printing, which is, as you see, just one of the modalities available. Okay, a few words about the actual medical applications. As I mentioned, the dentistry. As you know, in dentistry there is lots of manual work required and lots of precision required. If you compare, like on this graph, if you compare how the dental crowns are being produced, and you check the comparison of the model with the actual specimen, you may notice that all these red and blue colored areas are the mismatch areas. When you use the traditional methods, like milling, you don't get the perfect match with the actual object. With 3D printing, you may get the perfect match, and you see there are no difference at all with in the shape of this artificial crown. So dentists became important members of 3D printing society. Even when you look at the reviews of the dental printers, which actually look like any other reviews that you may read in the Google or other resources on any object. Then for dentistry, this became a really important tool with wide range of the materials being used, with also applications in education. One may print the specific, problematic patients' cases, like for the students, with a material that would be quite comparable in the physical properties to the actual teeth. Staying in the head and neck area, we could introduce the aspects of the reconstructive surgery and the designing of the implants. You see a patient with a large neurocranial defect who has been scanned, and you see the scanned CT scan is being used to produce the 3D model. And the increasing availability of 3D printing and the demand for 3D printing for such purposes results that at present most of the vendors, when you get the new workstation for diagnostic imaging, they offer the export to STL format immediately from the workstation. Of course, it requires some modifications, but still it improves the workflow significantly. So after designing after getting the model of the head and designing the missing part, one could produce, using the SLS technique, and so you may design the perfectly matching implant that may be inserted into the patient, and the effect is quite amazing. Not only the missing parts of the neurocranium may be used, but the viscerocranium as well. And this is an example of the 3D printed skull of the motorcycle accident victim who lost a large part of the lateral wall of the orbit and of the maxillary sinus. This part has been designed by producing the sort of mirror image of the opposite side, which allows for the perfect match, so that it improves the cosmetic outcome as well. Not only the titanium implants may be used, but also the low weight photopolymers, which would be used in the STL, in stereolithography modality. So some of these materials may also be used for implantation directly into the patient. 3D printing may be used also for planning the minimally invasive procedures. Something that may not look really amazing is quite interesting, because it's an elastic material used to print the bile ducts of the specific patient, and for testing the new type of the biliary stent that will be implanted into this model, which allows for like pre-matching the specific stent to a specific patient. This is the great advantage of the rapid prototyping techniques, that they allow to produce the physical objects on a very limited number. Because, as you may expect, does it make sense to use the 3D printer to produce like 100 copies of the, I don't know, typical bone, let's say, I don't know, femur? Well, of course it doesn't make sense. But if you, because you have other like molding or other techniques that will produce lots of copies of the exact same object. But the great advantage of the 3D printing or rapid prototyping in general is that you may produce unique models. So if you have the specific patient to design the procedure, if you have some uncommon anomaly of the bile ducts or blood vessels, whatever, you may deal with the physical object of this specific patient, which is unique. Similarly, for the carotid arteries, you'll see the specific patient's arteries model may be printed, so that then to measure how much of the pressure must be used to open the stent in the specific artery, regarding the specific anatomy of this actual patient. The bottom line is that such designing the procedure in vitro, I could say, will shorten the time of required for the procedure, decrease the amount of radiation, decrease the amount of contrast media, and shorten the time of the procedure, which from the hospital perspective matters also if you can fit 6 procedures per day instead of 5 procedures per day. So all that helps improve the specific patient care, but also the whole workflow in the hospital. Similarly, on the bigger scale, you may deal with the planning the much larger surgical procedures, like in orthopedic surgery, and designing the stabilization casts for specific patients, for the specific type of fracture, so that even to guide the screws that will be used to fix this device in the specific patient, so that again you use your material as effectively as possible. It also matters if you're dealing with a large scale, then it matters how much of this material you have available and how much of the waste byproducts you get after producing such equipment. Similarly, for the spinal surgery, you may notice the vertebral body here destroyed by the tumor, and supposed to see how deviated on the lateral view the vertebral column is, but also the abnormal curvature on the sagittal view is. And in this patient, the three versions of the cast that will be used to replace the vertebral body have been produced, and after adjusting them on the 3D printed model, just one of them has been used in the specific patient. Staying with the minimal invasive procedures, personalized stents. Stents that you may measure the physical properties. This is how the elasticity is measured, how the size changes of the stent, and the stent that may be produced for the specific applications regarding the diameter, regarding the length, so all the dimensions that may be matched to the specific patient, specific location. And similarly, when you're dealing with the aortic stent grafts, as you see, there is frequently in large abdominal aortic aneurysms, you facing the problem of the arteries that arise from the portion of the aorta that would be covered by the stent graft. And what can be done? The fenestrations may be done in such a stent graft. Then why not print the model of the aorta and then localize these fenestrations so that they would perfectly match the actual patient's anatomy, so that there is no risk of some dissection of the artery, or that some portion of the artery or origin would be covered by this non-fenestrated part of the stent graft. And this is the stent graft already prepared for the implantation in the patient. So again, personalization here would be the keyword, and the optimization of the outcome. As I said, it's hard to imagine the branch of medicine where there would be no application for the 3D printing, like for example hearing aids. What you see here is the company materials, which uses the smartphone to produce the 3D cast of the external ear, which may be used then using artificial intelligence to optimize the design of this implant, and the actual device may be produced using the data that has been collected by the smartphone. You could say, well, what's the big deal? You can go to the specialist and have it done, well, fully professionally. But again, think of the remote locations, of the limited access to the specialists in some areas. Such a solution allows for the improvement of this availability of the healthcare. And minimizing the scale this time, we should mention the tissue engineering and the application of 3D printing, where the tissues are being produced from the single cells, where the scaffold for placing the cells may be produced with the 3D printing, and then such models may be used for studies in the drugs and physical effects of the chemical substances into the cell cultures, so that you may test the effect of the drugs and other substances in more life-like conditions. So that will be the 3D printing, which I hope you found interesting. It has some well-recognized position in medicine. But now we will move on. And as we started with a sort of earthquake, now we'll be rising the tension. And who said that? Makes sense, but it didn't. Alfred Hitchcock, perfect. So this way we moving to the artificial intelligence. So as I said, something that we still don't know, and for a long time we will not know where will it lead us, and what outcomes will it bring. I don't think that computers getting rid of humans like in Terminator movie would be some real life scenario. But well, let's still be careful and check what is going on. Now, see, there is actually no branch of the life or the civilization that would not be affected by the artificial intelligence. We have the entertainment with sports, we have healthcare with multiple uses, but defense, smart homes, insurance. Artificial intelligence produces the really excellent models that predict the risks, even in the insurance industry. In smart homes, even my home camera system suggests if I submit my videos for training the AI that recognizes the human body in the videos, I'll get some discount for future products. So, well, of course, it is a huge business which affects much more our life that we are aware of on the regular basis. So, few ways of introduction, just like with the rapid prototyping, similarly with the artificial intelligence, what are the types of solutions that are being in use and some terminology that we may find. So, most important terms that would be artificial intelligence does not require the explanation, of course, but we have a few types of this technology that we should introduce, most importantly the machine learning and natural language processing, which I believe would be the most important ones and most widely used, because the physical robots, also AI has applications in this field, however quite limited. And robotic process automation is purely digital process, like automation of the processes that are in the hospital information systems may find applications. But I would like to focus on the machine learning and the NLP, which is natural language processing. So, what is the machine learning? Machine learning will be the most common applications, one of the most common applications in healthcare, which is what we call the supervised learning, which means that we train the computer systems to produce the models to predict the outcome. Whether for medicine, this outcome may be, shorter hospital stay, survival of the patient in some cases, rejection of the transplant, risk of the kidney failure after the contrast medium injection, and so on, and so on. So what we need for this supervised learning is, of course, the data sets. And I'll show you some examples that the size of the data sets here is essential factor that influences the outcomes of the artificial intelligence, because it must be trained on as many examples as possible, because only in this way it will be able to recognize some patterns, because it requires sometimes the hundreds of thousands of examples to predict possible versions of the process or versions of the particle or of the specific arrangement of the amino acids in the protein. So this is, you could say that the machine learning sounds like something that, we actually know from the statistics. Because any models that have been in use for years in the statistics, starting with the most primitive ones, like the Pearson correlation. Increase in value of one parameter results with the increase of value of another parameter. This is prediction model, very primitive, but still is a prediction model. Then you move on to the regression algorithms, which will take into consideration multiple factors and allow for bringing some weight factors so that one factor influences the outcome more than another. But it's still producing the prediction model. And if we make those models more and more complex, we get to the neural networks, which allow for the production of models which have been a sort of breakthrough in modeling, because the neural networks allow for the multiple processes to like compare different versions of the model. But actually, what we get is we provide some input to this model and we get some outcome. But actually, how does the model adjust those weight factors to specific parameters? We do not actually know. That's also why it's called the neural network, because it simulates how the human brain works. We cannot predict how one person would analyze the same set of factors or the same set of parameters as another person. So that's why in the neural networks we have those hidden layers, and depending on how complex machine is and how much of this how strong computer you have, you may produce them more and more complex. So that's where we get to the deep learning, which allows for the analysis of a huge amount of data. In particular, in imaging, it's also found some applications which I'll discuss in more detail. And also deep learning will be used in the speech recognition in natural language processing, because this is an important breakthrough in the artificial intelligence applications. This is the producing or analyzing first, but also producing the speech that would be comparable to the actual human one, which may be used, for example, to analyze very basic aspects, to analyze the dictated notes. Even during the surgery, when the surgeon is producing the notes by dictation, the artificial intelligence applications may write down the actual text, which again improves the resource utilization, because you don't need 1-2 persons who would be required for this work to be done. Natural language processing, what you find also, you may find those advertisements of those automatic translators. You may speak to the device and it will produce the different language version almost immediately. With the progress of this technique, we may think of what will be the possible consequences for the education. Will the learning other languages will remain important, and also for the workforce perspective? What about nowadays we have the large corporation, we have people who speak some uncommon language. Yeah? They are extremely important for the corporation and will get paid extra because the company needs those people. Will it be so in a few years perspective? We don't know. So to summarize, we have those three terms that we should be aware of. So we have the artificial intelligence, so the programs that can simulate the human behavior regarding reasoning, acting, and adaptation. We have the machine learning, which is the algorithms which improves, it learns with time as exposed to more and more data. And the deep learning here is the multi-layered neural network that learns from this vast amount of data. Speaking of the artificial intelligence, we should of course mention the few most widely recognized concepts that are always somehow in the background. Of course, Alan Turing and his Turing test. So the matter will be capable of distinguishing whether they are talking with the human or with the computer. The studies on the artificial intelligence and the language processing have been one of the oldest applications of the artificial intelligence and the machine learning. And there is this anecdote, for example, where for testing, of course, lots of these applications used to be the military, so in the Cold War era, there was this research done on the language processing by translating the English phrase to Russian and then translating it back to English to compare how effective these algorithms are. And, for example, translating the first steps of this training, the phrase, spirit is strong, but the flesh is weak. Yeah? Translated to Russian back to English with the statement that the alcohol is strong, but the meat is rotten. Something that the human would realize that something is wrong. So with this intelligence, we still well far from this algorithms being perfect. However, especially in the European Union, you may notice that there is the awareness of the threats that the artificial intelligence may bring. So I would say European approach to the AI is much more conservative than, for example, the American one. If you look at which of course reduces the the development rate of the companies that provide these solutions, but at the same time, also in the United States, there have been discussion on feeding those algorithms with the publicly available data, like the books that are the common license, but also the newspapers, all the information that is used for training should be available, should be done with no fees for the artists, for the authors of this works of art. That remains an open question. In Europe, this approach is much more conservative, as I say, and this is a European Parliament initiative, which specifically for healthcare applications shows the at least 6 possible risks of the artificial intelligence. This is, most importantly, who will be responsible for the mistakes that those algorithms do. At the same time, nowhere the AI would be allowed to make independently the decisions to the patients or in other aspects of healthcare. So, but what happens if it will be so, especially when we're talking about the limited human resources availability, and we introduce the AI sort of to improve the workflow. What happens even if at this stage there will be some mistakes? This is the risk of the misuse for some non-medical purposes. This is the issue of bias and the perpetuation of inequities. It has been widely known some time ago when some AI algorithms trained on the material from the social media have been becoming very rapidly aggressive, racist, and so on, because they simply copy what they observe. There is no ethics in the algorithm. Yeah? It just does what it has been trained with. So selection of this data that is used for the training of the algorithms, which also is related with the privacy issues and with the lack of transparency. In radiology, there is a discussion whether one could use let's say, chest X-ray. Is it the personal data or isn't it? Should be protected even if it's anonymized. Is it still the personal data that allows for identification of a specific person? Sometimes it does. You may have the patient who will have I don't know, very uncommon disease, very uncommon, I don't know, chest malformation. You could say that chest X-ray is the same personal data as your, I don't know, ID number. So there's lots of privacy issues related with that. And these risks are what we should be aware of And with time, probably this number, the significance of this risk will be only increasing. We also must be aware of one more issue, because so we must be aware that this intelligence, in the term of artificial intelligence, is also should be used cautiously, because do you need intelligence? Maybe strange question for the radiologist to ask. But do you really need intelligence to analyze the radiological images or pathological specimens? Well, as you see, with good training which also means some benefits for the observer, with some good training, you can train even pigeons to distinguish between the breast mammograms and the pathology specimens, to distinguish between the cancer and non-cancer specimens. So, with this intelligence, also in the real life, you could think of some cases where this intelligence is rather brings more problems than benefits. But I asked a few AI engines about the future of medicine. And a technical comment. Sorry for this length of this and the small font, but I wanted to squeeze as much information as possible. But I asked Grok. Speaking of possible algorithms, I must admit that I would like to warn you also that this, as I said, intelligence does not mean ethical behavior. Use the AI algorithms really carefully, especially when you generate some data. Make sure that the data that you get is true and validated with some other sources. So, lots of false citations that you may find, lots of misconceptions that will be given to you, which sounds really reasonable. When you get to details, it turns out that it actually doesn't make sense. Out of the 3 possible solutions here, I used the Perplexity, ChatGPT, and Grok. I must admit that the Grok was the most reliable one, which still does not mean that there were some points for improvement and to modify some misconceptions. But still, it's just like here, it's like you speaking with other human. One will be more reliable than another. But back to the specialties. What does the AI say about the future of medical specialties? Radiology, and probably you may expect in all the possible algorithms, radiology will be always listed as the first. As the analysis, and we must admit, analysis of the image is what the AI will be extremely efficient with, even more than those pigeons from the previous slide. Why? Again, size of the training data. Yeah? If you train the AI algorithm with, let's say, 100,000 chest X-rays, this is more than probably I will report in my lifetime. And even if I do, I will, of course, after few years since I start, I will forget what I've seen before. I will be tired, I will have the bad day, I will be in hurry, I will be missing things. The computer will not. This is what we, of course, must admit. So hopefully radiology is not only about looking at the pictures, so still I believe there is some chance for us. Similarly, pathology, dermatology. Again, if we reduce these specialties just to looking at the images, then of course you would say, run. Hopefully, it's not just about this analysis of the images. Of course, specialties that will be less likely to replace, and the same will be with other algorithms as well, will be those where you require the direct contact with the patient, and you perform some procedures. This is where the AI will have the limited application. So again, if you choose the radiology and would like to be on the safe side, think of the interventional, because here the chances are that the AI will replace you as the last of the subspecialties in the radiology. ChatGPT admits the high risk of a disruption, but hopefully again not total replacement. Again, radiology is on the first place. Similarly, pathology, dermatology, ophthalmology. Also, I'll have some examples like the analysis of the fundus of the eye with some retinal malformations in blood vessels. This is what the AI will be amazing with, again, because it's image analysis, which those algorithms are really good at. And perplexity. Again, radiology on the first place, unfortunately. However, and interesting information. 2022 study showed that the AI concerns deterred 16% of students who were considering radiology as their future career. So that sounds interesting. And well, as I said, I would still say that this is. Maybe not nothing to worry about, but we must be aware that all the medical specialties will change with the AI widespread use. Radiology will be among them, well, definitely. But still, I used to work for 20 years, and my first years of work, we were using the typewriters and the negatoscopes and the X-ray films. So I already survived digital revolution in the radiology. So I hope that we'll also survive the artificial intelligence revolution. But of course, the face of the specialty will change. What uses do we have for the AI then? Speaking of the radiology, you must introduce definitely the stroke detection. Here, there are some solutions that are widely used even in my hospital. But what I wanted to draw attention to is the size of this training data sets. Please have a look. The Radiological Society of North America Brain CT data set for training is almost 1 million cases. Yeah? So it's enormous. This enormous amount of the scans that are used for training. But still, those algorithms will do mistakes. From my observation, this is whenever you have the suboptimal data study quality. Yeah? The patient moves, for example. The patient is positioned improperly. There is something unusual. This is where human perception will work and will, reasoning here and your experience will help you avoid the mistake, which may be misdiagnosed by the AI, which follows the statistical distribution of in its reasoning. So as you see, there are actual devices or applications that use the AI for this. As you see, deep learning will be the most widely used modality here because it's about just analyzing huge amounts of data and learning from this data. Brainomics is one of the applications that are widely used, and this, as I said, this one is used in my hospital, where the radiologist and neurologist get the immediate results. Even on their cell phone, you get the result of the analysis of the blood vessels, stroke area, perfusion parameters, all that influences the progress with the patient treatment. So this is what is actually working nowadays, and it's working quite fine. But still, in unusual situations, it shows that still the human perspective is necessary. Staying with the imaging, the segmentation of the medical images. We use lots of three-dimensional models. For example, we use the measurements that could be automated using the AI algorithms, and they are also nowadays they are widely implemented in the software provided by specific vendors of the medical imaging equipment. Interesting solution because so far we're talking just about the simple analysis of the image, but here you may notice, and this is implemented in the actual imaging equipment as simple as the portable X-rays. The limitation of for the portable X-rays, or the drawback of this modality, is that the radiographer goes to several departments and comes back to the department with some, let's say, 30 X-rays produced in several hours sometimes, and then starts uploading them into the hospital system. Now the question is whether some of those X-rays should be reported more immediately than others, and here the AI helps. How look, if you train the AI algorithm to identify the pathologies like pneumothorax, like pleural effusion, like atelectasis, like the foreign object, for example, you may notice how the patient's waiting time will be affected when the AI will identify those problematic cases and simply put them on the top of the list for reporting. Yeah? Here, the green bar shows the average report turnaround for the, when no AI has been used. So it was several, more than 1 hour, some 2 hours more or less. With any AI algorithm, this waiting time has been reduced significantly. For the normal X-rays, as you see, this change in the waiting time has not been significant. And these applications are in use even in the portable scanners, so it helps with this workflow organization on a daily basis. But still, from a patient perspective, this is really important that they simply do not wait like as a random patient on the list, but they go to the top. Neurological diseases like the Alzheimer's disease, as you see, the AI algorithms may improve the 3 times the progression of the Alzheimer's disease in several years period. And these applications are also in use by the medical imaging producers and implemented into the CT and MRI scanners, analyzing some areas which may be even unusual or would not be taken into consideration by the traditional analysis and traditional understanding of the pathology as the radiologist does. For neurological disorders, it's not only the image analysis. It could be also the voice analysis, which is known to change with time. But again, how much could the AI improve the detection rate? So how many months or years earlier could be the disease detected if this data was analyzed by the AI? This is what is happening, so again, worth knowing that it's not just the images. Also, radiology report generation. This is also where the structuralization of the report, maybe it's not something that sounds like something challenging for the regular reader of those reports. But for example, when you work in like multinational company, for example, you may get the report that will be automatically translated into several languages. So that helps. This structuralization really helps. Obviously, identification of the fractures, especially on the X-rays. Here again, huge amount of data used for the training will help with this identification. And again, not all X-rays are reported by the radiologist. Lots of them are analyzed just by the orthopedic surgeon, who orders them like for their own use. Still, this aspect could be introduced so that to improve this fracture detection, which simply would not be done otherwise, because it's done like sort of outside of the radiology department. Cancer detection, as I mentioned, the mammograms. This is what is extremely important, and as you notice in here, from Northwestern University, you see the mammograms where 6 radiologists failed to find the cancer, on the mammogram, but it's been positively observed on these mammograms by the AI and confirmed in the specimens. So again, experience, not being tired, and huge amount of data that is used for training. This is what is beyond the access to the regular human. Also interesting aspect is the drug research and molecular research. One of the aspects that are analyzed in the pharmacology is, for example, the shape of the proteins. When you design some molecule, how will it behave? As you know, all the genetic code contains is the sequence of the amino acids. But the sequence results with a specific folding of the protein. And again, if you're designing some enzyme, for example, you would like to be like temperature specific, be activated by temperature, or would be more effective than the natural enzyme. You can use these tools to design those proteins that would be more effective, more stable, or unstable in some specific conditions, if this is what you're interested in. Again, freely available website. However, again, calculations and the power of the computers. Yeah, the typical freely available version allows for some 300 amino acids only. Again, number of calculations here is enormous. But it's still being used, and this technique has been used for the first drug that has been designed by the artificial intelligence that has been introduced to the clinical studies, has been antibiotic, and original molecules that have been analyzed by the AI algorithm were 25,000 possible molecules. Out of these molecules, several hundred have been used to be produced, and then out of these 25,000, just few have been brought into the further analysis, and that shows how much of this improvement may be done regarding the time, regarding the workflow, because to design such 25,000 molecules would take probably years in the regular approach. By the AI algorithms, it will be done within several hours. So this is enormous improvement, in this acceleration in these studies. This is the AI algorithms have been used in the COVID vaccines synthesis research, also for preliminary rejection of the useless particles that would be not effective, and only several chosen would be used for further analysis. This shortens the research time dramatically. What else? I mentioned at the first slide about the medical applications of AI, the robots. And if you read, this is from the Stanford University press materials. So I'll see how interestingly the title has been produced. Yeah? Robots watching surgery. When you read the title, well, you think, of course, that you see like the robots sitting in some cinema and watching the surgery video. Well, actually, when I get to details, it's about the observation of the movements of the surgical tools, but still, the studies show that the observation of those movements of the tools may improve the behavior of the autonomic surgery systems. So obviously, it's a long road before this will be used in the clinical aspect. But again, if AI could somehow modify the surgeon's movements, like that. Even nowadays, the robotic surgery allows for that the surgeon's hand movement may be translated to the movement of the tool in the patient, but at some rate, so that the movement of the hand of the surgeon may be sort of scaled down into what is going on in the patient. If AI could be introduced here to modify this range of movement, like to correct it, then there is a question again of the responsibility if something goes wrong. What else? Of course, EKG interpretation, obvious. The two important factors here to mention. One, this is a graph, so it's the visual data, so no surprises, it will be effectively analyzed by the AI. But what's important is again the number of data. Again, have a look at the training system, like from the Stanford University, almost 30,000 patients, yeah, with 60,000 EKG recordings have been used for training of the specific algorithms or specific programs. If you think of what is happening now in lots of medical branches, people want to live a healthier, longer life. There is increasing demand for some wearables. Yeah, you have the smartwatches, which will not only measure the pulse, it's quite obvious nowadays, but you have also ones that do measure the blood pressure almost instantly. So this amount of data, again, the companies accumulate this data and will use it to feed the deep learning systems and to improve the outcomes. So there is the huge future, I believe, ahead of us with this amount of the medical data that will be collected from really sometimes surprising objects or applications. Pathological sign analysis, obvious, this is what we've already mentioned. So here, no surprises. Again, as you said, even Pigeon could do that, just like reporting the chest X-ray. Nursing assistant, mental health chatbots. I assume that for all of us here in the room, the experience with chatbots is sort of, well, I haven't met a person who would be a true fan of writing on the chat with the chatbot, because easily you may identify this is actually the computer. But again, if you bring the speech synthesis to those chatbots, then it really changes the approach and will change the perception and possibly the effects on the treatment as well. Chronic diseases, as I mentioned the EKG analysis. Have a look at the diabetes. You have the companies like here, Diabiloop, which brings the modification to the automatic insulin pumps. By learning the patient lifestyle, by learning about the changes in the insulin level, the glucose level in a patient due to the physical activity, due to the type of meal that has been ingested, it may learn to improve the patient's blood glucose levels, may reduce the need for the insulin, but most importantly, it will reduce the number of possible complications. More for the future, prosthetic control. As I mentioned, this movement of the surgeon's arms, same would be possible to improve the work of the prostheses that are being implanted in the patient. Any type of graphical data may be analyzed, even for the sleep disorder analysis. You can use the AI, which will identify the apnea. Again, if it does it automatically, you still may need the physician or nurse to analyze the data. Yeah, but if we get the preliminary report, it's always easier to check the report that is preliminarily analyzed than to do it from the very beginning. If actually you have long records, like in the sleep data, or EMG data, or even Holter records. Again, such analysis, if the nurse may analyze 20 instead of 2 such reports at the same time, that affects the workflow significantly. So this is not only in this simple example, but also the optimization of the hospital resources, use of the drugs, use of analyze the admission rates, analyze the weather or moon phase affects the specific patient's conditions. This is what the AI may be used for, absolutely. Retinopathy is what we mentioned. The dermatology has been introduced as well. Endoscopy, we also have mentioned this one, so I will simply skip it. Heart failure is another example of the multi-factor analysis where the different models may be utilized, but still the more data, the better will be the outcomes. Nutrition. This is something that is maybe interesting. As you know, the personalized diets and analyzing the dietary habits is also what becomes more and more important. And well, if you add, for example, the AI applications like the snapcalorie.com allows you to measure the amount of calories from the picture that you take of your food. This is something that well, you know, we are lazy. We are lazy, and you know, counting all the, you know, how many grams of specific ingredient have been used is really really frustrating. If you take the picture and does its job, then it's really something that may work, even though it will be not as precise as we did the calculations on our own. Similarly, you could analyze, well, burn assessment. This is actual algorithm which LC allows for the prediction of the whether the skin graft will be needed, what will be the possible complications, what will be the hospital stay, by analysis of relatively simple factors. Again, what you need is large amount of data for this analysis, but it may work even on the single hospital level, where you use your own data and this will be comparable to, and the environment will be comparable for all your patients. And last but not least, the medical education. Here also we have the place for the simulated patient scenarios, for training for producing algorithms for improved learning, like you have Duolingo that will keep reminding you that you did not learn, and so on and so on. So wide range of applications. And as I said, the change that is happening now is something that of course will affect each of us sitting here, more or less depending on the specialty. From the radiological perspective, I would like to once again stress out that radiology is not just the picture analysis, but it's also analyzing other medical records, other test results, it's consultations with other physicians, it's discussing procedures and the results with the patient, and also the designing the studies. So there is still place for radiologists, just like for the dermatologists, just like there's place for pathologists in the future. To summarize, I would end with a citation from John F. Kennedy, who said that change is actually life. And you cannot only look at the past, you cannot only look at the present, because you will simply miss the future. So I hope that this sort of shows you that there is nothing to worry about. What we should be aware of is that the change is the part of the natural processes, and there has to be changes, because otherwise, if we do what we used to do around the whole life, others will come up with some other solutions, maybe better, maybe worse, but as long as they're trying, some of them will be better, just like in the regular process of evolution. So do not be afraid of change. Do not be afraid of the artificial intelligence, and simply learn to use it. Use it carefully. As I said, there is no ethics in those algorithms, so be careful when you're using some data that is generated by the AI. Thank you. If there are questions, then this is the time. No questions. Okay, thank you then. Dziękuję.
So we are very grateful to have you on board because still we don't have so many lectures like this during our studies, and I think it's not only our future but also our presence. So that's why we should be very familiar with this topic. And thanks to you now, I think we are. So thank you again. And I am very curious how we are going to talk about this topic maybe in a year, because the improvement is so fast. So that's why I invite you for the next edition of our beautiful event. Yes, so thank you so much now, and see you in the closing ceremony. Thank you.
Właśnie o to chodzi, właśnie jakby, no my czytamy, dlatego mówię, że to jest problem. Bo my to mamy jakby, i to nie jest
Okay, let me check the time, 1 second. It is afternoon. Good afternoon, everyone. My name is Amir, and I'll be assisting with the closing of the ceremony. I do have a script over here that says, "Dear guests, esteemed speakers, and participants," I believe all of you have been all the three. You lectured us through your work, and also you have been our guests, and also you participated in different aspects of the ceremony. Not only the ceremonies, but also the conference, the inspirational zone, the lectures, and presented us your works, and engaged, and we got to know each other. After 3 intense days filled with inspiring lectures, engaging discussions, and invaluable meetings, the time has come to officially close the 11th edition of the Lublin International Medical Congress. With great joy, we extend our gratitude to everyone who contributed to the success of this event, our speakers, participants, patrons, and sponsors. Without your presence and commitment, and also your contributions, this Congress would have not been possible. We would like to express our sincere gratitude to the Minister of Science for funding this conference under the program Doskonała Nauka Druga. Thanks to this financial resources, we had the opportunity to organize this event and provide a platform for knowledge exchange and scientific discussions. This year's edition welcomed over 350 participants from 20 different countries with more than 200 scientific presentations. I'm honored. This proves how our conference continues to grow as an essential platform for knowledge exchange and experience sharing in the medical community. We hope that this event was not only a source of inspiration for you, but also opportunity to establish valuable professional connections. We extend special thanks to our honorary patrons, including the rector of the Medical University of Lublin, Professor Wojciech Załuska, and also Lublin Voivod, Mr. Krzysztof Komorski, and also the Marshal of the Lublin Voivodeship, Jarosław Stawiarski, and also the President of Lublin City, Mr. Krzysztof Żuk. We would also like to express our gratitude to all the organizations that supported our conference: the Lublin Medical Chamber, the Lublin the Students' Council, my apologies, the Student Government of the Medical University of Lublin, the Polish Academy of Sciences, Lublin Division, the Academy of Young Scholars, and IFMSA Poland. We would like to also thank the institutions that provided the conference with scientific patronage: Society of Polish Internists, Society of Polish Surgeons, Polish Society of Epidemiologists and Infectious Disease Physicians, and also Polish Society of Hypertension. Not to forget, Club 30 of Polish Cardiac Society, Polish Neurological Society. Thanks to your support, we were able to create a space for fruitful discussions and knowledge exchange. We also extend our appreciation to our media partners: Medycyna Praktyczna, Blask, Akademickie Radio Centrum, Polskie Radio Lublin, Medforum, and edukacjemedyczna.pl. And of course, Bank PKO. And the next would be DOZ, and Interpolska, Corpus Mind, Więcej niż lek, Twój dyżur, Wirtualna klinika. I'm not practicing Polish. Medycyna Praktyczna, Mannequin, they really have good food. Kangomed, Ambara Zupiarnia, I had a lot of food from there. Red Bull, okay, last night. Compendium Medicine, and of course Remki, Spaware, Namy Medycyny Shop, Pożecia Pierwsza, and CEM Grupa LuxMed. And I believe, if I'm not mistaken, that would be for now. I would like to emphasize that I appreciate your engagement and support, as all of you have been amazing sponsors. Next, I would like to invite the chairman of the organizing committee of Lublin International Medical Congress, Mr. David Staniak to the stage to summarize this year's edition of event. Please welcome him with me with a round of an applause.
Ladies and gentlemen, dear guests, esteemed professors and incredible team members, as we come to conclusion of the 11th edition of Lublin International Medical Congress, I would like to take a moment to reflect on the incredible journey that brought us here today. Over the past days, we have witnessed inspiring workshops, innovative sessions, and lectures delivered by some of the most renowned specialists in the field of medicine. It has truly been an inspiring experience for all of us. First and foremost, I would like to extend my deepest gratitude to those who support and dedication made this event possible. A huge thank for the Vice Rector, Professor Camil Torres, for his guidance and belief in this initiative. A heartfelt appreciation to Deans Professor Halina Lach, the guardian of the Student Scientific Society, for her unwavering support. I would also like to express my sincere thanks to Mrs. Maryla Tembikowska, Mrs. Honorata Zaguła, and Mrs. Małgorzata Podgórniak for their invaluable contribution. Your dedication has played a crucial role in making LIM's unforgettable experience. The work on this Congress began back in May 2024. Over the past month, a remarkable team of 60 individuals, led by 11 outstanding leaders, dedicated their free time and energy to ensure that we could stand here today, celebrating the success of this edition. Their commitments, passions, and hard work have been truly inspiring. Now, let's make a moment to express my deepest appreciation to our exceptional team leaders. Maja Kopyto, team leader scientific session. Thanks to Maja, all scientific sessions were carefully planned, allowing you to present your work in a professional setting. Please, Maja, go to the stage. Magdalena Mortka, Team Leader Workshop. I hope you all found the workshop engaging and insightful. It was thanks to Magda that you had the opportunity to participate in them. Thank you. Martyna Pawłat, Team Leader Lectures. Bringing in top specialists from various medical fields was Martyna's doing. Thanks to her, we all had to change to listen and learn from leading experts. Amir, Team Leader IT. Amir, despite joining at the last moment, and you did an incredible job. Thank you. We have a smooth online connection throughout the event. Thank you. Maximilian Severin, Team Leader Logistic. Delicious food, smooth registration from early morning, and the beautiful setup of our conference center, all thanks to Max. Ania Kozłowska, Team Leader Contact and Email. Whether it was 6 a.m. or 2 a.m., Ania was always there, ensuring that all information was communicated effectively. Kasia Witczak, Team Leader Procurement. Those wonderful gift bags? That's all thanks to Kasia's hard work. Madzia Zapalska, Team Leader, Partners and Patrons. All collaboration and prizes were endorsed by Magda. A huge thank you for your efforts. Aleksandra Makarewicz, Team Leader, Inspiration Zone. A brand new future at our conference. I hope you all enjoyed it. Thank you, Aleksandra, for bringing this vision to life. Małgorzata Zgodzińska, Team Leader, Graphic Design. Every visual aspect of this Congress designed with hour of hard work in Canva was Małgorzata masterpiece. I hope you all love it. Maria Materek, Team Leader, Social Media. Every bit of content you saw online was thanks to Maria's dedication. I'm so glad our social media presence reflected the energy of this event. There are There are truly no words to express my gratitude for all work you have done. If at times I made things difficult for you, I sincerely apologize. But if I had to do this all over again, I would choose to do with you, without a doubt. Thank you very much, and stay. Wait a minute. Gdzie są moje książeczki? Takie moje kartki. O, tutaj. Dobra. Of course, LIMS is not only about the leaders. It is also the result of the enormous effort of volunteers who dedicate for 3 hours to ensure everything runs flawlessly. To each and every volunteer, thank you for your time, commitment, and energy. Your work has not gone unnoticed. Now, I invite you all to come forward and show the world the incredible strength of this team. Together, we have built something extraordinary. Please, every members of team, please come to this stage, because it's a big applause for these members. Yes, come. It's a big team, but I think it's the best team in our university. Make a big applause for these people. Thank you very I can confidently say that LIMS is not only the largest, but also one of the best student congress in Poland and Europe. Thank you all and see you at the next edition. Thank you.
A round of an applause for him, the president of the conference, LIMS 11. Come on, once again. Thank you, David. All right, so now we would like to invite Ms. Maria Materek, chairwoman of the Student Scientific Association, to the stage with a warm welcome.
So every time I hate talks after the David because he always have a beautiful speech and he present us like a superhero, but we are exactly not. So I have few words for all of you. I promised myself that I wouldn't be crying, but it's really hard for me because everything what is happened here brings me so many emotions, and I'm really grateful that I can meet here so many people, beautiful and amazing people like all of you, and I'm really happy to be part of another LIMS. And I would like to extend my heartfelt thanks to our professor, Halina Lach, for her support, warmth, and faith in us. Professor, we are deeply grateful for everything, for your help, for an inspiration you give us every day. Thank you for always being there for us with kind words and advices. And also, we will not be here if David not be here exactly. So I have no words exactly to thank David for all of this work. David, once again, you have demonstrated that your passion, determination, and dedication make LIMS an event for the highest standard. Your hard work and your attention to details ensure for this conference it's not just an event. And I'm sure that you will see. You see it, everyone. And without you, this Congress wouldn't be the same, I think. I'm truly delighted that the bar has been set so high, and I'm certain that your example will serve an inspiration for future organizers this conference. So thank you, David, for everything. And as I said at the beginning, I hadn't such a beautiful speech like David, but I want to thank you, all of you, to being here and to being a part of another LIMS, and I hope that the next year we will see you there. Thank Thank you.
At this moment, we're honored to welcome Professor Halina La, Dean of the Medical Department and Supervisor of the Student Scientific Association at the Medical University of Lublin, to deliver the closing address and present the awards you have been waiting for.
Ladies and gentlemen, our honorable guests, dear students, as you see, our Congress is slowly coming to the end. But firstly, I would like to say thank you, all our participants. I know that the scientific level of this conference was very high, so sometimes it was very difficult to choose the winner of particular sessions. So I congratulate all winners. You have presented the results of your scientific work in professional manner, and you can be proud of your presentation. Secondly, I think that on my own behalf, but I think that on behalf of all participants, I would like to congratulate organizers of this conference. Marysia Materek, Dawid Staniak, Maja Kopyto, and all students who take part in organization of this event. You organized this conference perfectly, personally, and professionally, and I can say that our adult conferences in which we take part as academic teachers, as researchers, would not be ashamed of such wonderful organization. I'm proud of you, and I think you can be proud of yourself. And I think that finally I can invite all of you to the next edition of the LIMS, which I hope will be held in 2026. So thank you very much.
Okay, now it's time to giving you your awards. So please, Professor, come with us, and we start. So the third place in a basic science ones goes to the Julia Szewczyk of paper titled "Comparison of Methods of Detection of Methicillin-Resistant Staphylococcus aureus." Please come. The second place goes to Maciej Baron with presentation MER 143 are correlated in myocarditis correlation study. Please come. And the first place in a basic science ones goes to Maciej Jędrychowski with presentation Detailed Surgical Anatomy of Head and Neck in Life, like 3D models of human cadavers. Please come. Yeah, we have Veronika to, and please moment of photorelation.
Okay, so now the session Basic Sciences 2. The third place goes to Marek Rybak for his work Cytotoxicity of commercially available essential oils blends used in supportive treatment of upper respiratory tract infections. Second place, Alicja Szklarska, for her work titled Possible Usage of Selenium in Decreasing the Adverse Effects of Lithium Therapy, a preliminary study on LN-229 glioblastoma cells and H222 hippocampal cells. And first place, Karol Jakubik, for his work entitled Analysis of butyrophilin's expression in peripheral blood mononuclear cells from acute myeloid leukemia patients.
Okay, now it's time to gynecology case reports. The third place goes to Alexander Siwek with presentation of the paper titled The Impact of Sclerotherapy on Ovarian Stimulation for In Vitro Fertilization. The second place goes to Zuzanna Skiba with presentation Silent Growth to Sudden Symptoms, a rare case to large mature ovarian teratoma in an adolescent. And the first place goes to Natalia Gierulska with presentation is Durvalumab, an effective treatment in recurrent endometrial cancer. Case report.
Okay, so now internal medicine. Third place goes to Krzysztof Żerdziński for his work The Lactate to Albumin Ratio and CRP to Albumin Ratio as predictive elements in critical ill patients. Second place goes to Gede Aswin Parisiasismana for the work entitled Anthocyanin-rich Clitoria Tanera extract ameliorates perivascular adipose tissue dysregulation in rat with high-fat diet. And first place goes to Zuzanna Guzowicz for her work entitled Vitamin D Deficiency Among Seniors of Lublin Voivodeship. Is the supplementation needed only seasonally?
Internal medicine case report 1. The third place goes to Sebastian Wiśniewski with for the presentation the paper titled Trilateral heart and left atrium appendage clause in a patient diagnosed with permanent atrial fibrillation. Case report. The second place goes to Katarzyna Siemieniec with presentation Severe Nephrotic Syndrome in Pregnant Women with Systematic Lupus Erythematosus. A case report. And the third place goes to Nicole Kosmidar with presentation, Development of Invasive Furiasiosis in a Hematoma-Oncological Patient Case Report. Please come.
Now it's time for Internal Medicine 2 case report. Third place goes to Kamil Górecki for his work Innovative Insulin Therapies in Pregnancy, Transforming Fetal Outcomes and Reducing Complications. Second place goes to Zuzanna Czeczelewska for her work entitled Biologically Benign, Functionally Malignant, How to Deal with Myxoma. And the first place goes to Maciej Dubaj for his work entitled Lymphoma, a disease of more than one system.
And the last internal medicine case report, 3. The third place goes to Diana Oana Purdy with presentation Anatypical Pathway, Psoriasis Muscles Metastasis in Advanced Pancreatic Tail Cancers. The second place goes to, sorry, but it's very difficult, Austrina Kubiliut. Yeah, it's Austrina Kubiliut, yeah. With presentation, refractory ulcerative colitis associated with autoimmune hepatitis successfully treated with IAK inhibitor. And the first place goes to Monika Kalicka with presentation 1 in a Million, How Chest Pain Related Agenetic Diseases.
Okay, so now neurology and neurosurgery. Third place goes to Visitiu Alin Stefan with work Atypical Neurological Manifestations, the Challenges of Differentiating Between Lyme Neuroborreliosis and Multiple Sclerosis. Second place goes to Jan Krzowski for his work entitled Comparing the Effectiveness and Prognosis of Patients Using Autograft versus Synthetic Grafts in Peripheral Nerve Reconstruction. And first place goes to Kaumudi Manmohan for the work entitled Autoimmune Encephalitis with Anti-Caspr2 Antibodies Presenting as Seizures.
Now time for oncology. The third place goes to Lazar Lyubotin with presentation Evaluation of Clinical, Morphological and Pathohistological Characteristic of Glioma. The second place goes to Filip Krzanowski with presentation Autologous Hematopoietic Stem Cells Transplantation and Fluoroquinolone propylasis in the aspect of Clostridioides difficile infection, a single-center experience. And the first place goes to Sandra Murawska with presentation Exploring Metmorphin Therapeutic Potential in Non-Small Cell Lung Cancer, an in vitro study.
And now it's time for oncology case report. Third place goes to Wiktoria Sobocińska for her work entitled Case Report of Plasmablastic Lymphoma Patient with HIV Infection. Second place goes to Barbara Bobowska for her work not necessarily in the lymph nodes, the case of a 39-year-old woman with skin T-cell lymphoma. And the first place goes to Katarzyna Stępniak for her work Silent Signals, Facial Nerve Palsy, Unmasking Acute Lymphoblastic Leukemia in a Child.
For pediatrics and neonatology, the third place goes to Kacper Bartosik with presentation Clinical Course and Treatment Outcomes of Eosinophilic Esophagitis in Children. The second place goes to Natalia Biedroń with a presentation Trends in Congenital Abnormalities of the Kidney and Urinary Tract in Newborns and Risk Factors, a single-center retrospective study. And the first place goes to Katarzyna Witczak with presentation BDNF in Childhood Obesity and Type 1 Diabetes, a bridge between the brain and metabolism.
Now it's time for Pediatrics Case Report 1. The third place goes to Jakub Prośniak for the work entitled Treating the Test Results or the Patient, Thrombocytopenia in a Pediatric Patient. Second place goes to Milena Polewka for her work Gordon Syndrome with incomplete clinical manifestation in a 10-year-old patient with osteopenia, a case report. And the first place goes to Barbara Bobowska for the work entitled Diagnostic Challenges in the Rare Spinal Epidural Abscences in an Infant.
Okay, and the second case report, Kuba, please come to sign. Yeah, thank you. The third place goes to Larissa Yanala Tizou with presentation Localized Scleroderma and Overlap Syndrome, Key Differences and Clinical Implication. The second place goes to Julia Ziemińska with presentation, A Life-Threatening Emergency, Tumor Lysis Syndrome in a Pediatric Patient with Burkitt Lymphoma. And the first place goes to Zofia Moskal with Variability of Clinical Symptoms in Children with the Bardet-Biedl Syndrome.
And Pediatrics Case Report 3. The third place goes to Magdalena Kwiecień for the work entitled Diagnostic and Therapeutic Challenges in Chronic Granulomatosis Disease with Coexisting Atopic Dermatitis and Hypogammaglobulinemia. Second place goes to Agnieszka Piruk for the work entitled Severe Hyponatremia, a Diagnostic Challenge in Pediatric Nephrology. And the first place goes to Agata Dusha for the work entitled Respiratory Distress in Course of Lymphoblastic Lymphoma in 11-year-old.
Radiology and nuclear medicine. The third place goes to Anna Halot with case report on a 10-year-old patient with pancreatic duct calculus. The second place goes to Michał Flis with successful treatment of ruptured giant aneurysm of arterial usuria with endovascular means only. A case report. And the first place goes to Andrzej Zuzak with When the Heart Breaks the Rules, a rare case of quadricuspid aortic valve in a 60-year-old.
And now surgery. The third place goes to Nikodem Kuczyński for the work entitled Meniscal Regeneration, Opportunities and Challenges. Second place goes to Amir Nur Mohammadi for the work entitled Current Strategies in Inguinal Hernia Repair, Mesh and Suture Techniques. And the first place goes to Weronika Michalik for her work entitled Low-Cost Patient-Specific 3D Anatomical Models in Orbital Wall Reconstruction.
Surgery case report 1. The third place goes to Iga Wawrzyniak with When standard approach fails, a case of blunt abdominal trauma. The second place goes to Kamil Górecki with foreign body in the heart, serious threat or minor incidents. And the first place goes to Tomasz Jankowski with presentation, a typical presentation of acanthomoeba keratitis in a 48-year-old woman.
Surgery case report 2. The third place goes to Michał Lewandowski for the work entitled Pseudoaneurysm of the popliteal artery as a complication of infective endocarditis. Second place goes to Sara Wardenga for the work entitled Defying the Odds, a boy's journey through fatal syndrome. And the first place goes to Jakub Patek for the work entitled Surgical Management of Renal Cell Carcinoma at Various Stages, a Case Series.
Our conference is not only for students, also for doctorants. We have a PhD poster session and a PhD session. And for PhD poster session, the third place goes to Michał Wroński with a presentation Qualitative Analysis of Ralexifene Transformation Products during Photostability Studies. The second place goes to Magdalena Zabudowska with presentation assessment of the concentration of kininorein pathway metabolites and the impact of vascular calcification in an experimental rat model of chronic kidney disease. And the first place goes to Agata Małek with bivenom effect on glioblastoma cells, MMP2 and MMP9 secretion.
And now PhD session. Third place goes to Jakub Kosidło for the presentation entitled Evaluation of Laboratory Biomarkers in Acute Pancreatitis. Second place goes to Monika Kopeć for the work entitled The Evaluation of Ovarian Tumors During Pregnancy and Their Impact of Perinatal Outcomes, Retrospective Clinical Control Study. And the first place goes to Kinga Brzuszkiewicz-Łozowska for the work entitled Complications After Transcatheter Aortic Valve Implantation at the Cardiology Clinic of the Medical University of Lublin in 2013 and 2023.
And the next is poster session. The third, poster session 1, the third place goes to Julia Soja with presentation In Vitro Meat in an Awareness of Medical Students, a study of ethical, health and social attitudes towards lab-grown meat. The second place goes to Jessica and Balisa Scherer Fernandez with presentation Optimizing corticosteroid therapy in pediatric infectious mononucleosis, a comparison of prednisolone, dexamethasone, and administration routes. And the first place goes to Aleksandra Opęchowska with presentation Impact of metamizole therapy on T lymphocyte profiles in newly diagnosed pediatric Graves' disease patient.
And now poster session 2. The third place goes to Michalina Reimos for the work entitled Sundowning Syndrome in Dementia, Mechanisms, Diagnosis, and Treatment. Second place goes to Justyna Wołos for the work entitled The Role of Central Vein Sign in Multiple Sclerosis Management, a Systematic Literature Review. And the first place goes to Jelena Amidzic for the work entitled Clinical Profile of Alcohol-Dependent Patients According to LESH Typology 1 year after COVID-19 pandemic comparative study.
And psychiatry, psychology, and human science in medicine. The third place goes to Emilia Labutute with presentation Treatment-Resistant Depression and Ketamine Systematic Literature Review. The second place goes to Olivia Froń with presentation Age Regression, a case of coping mechanism in sexual abuse for 40-year-old boy. And the first place goes Mirella Wojciechowska with presentation, level of knowledge about kidney transplantation and the severity of depression, anxiety and stress in patients before the procedure.
And now public health. The third place goes to Aisha Hadar for the work entitled Factors Associated with Time to Return to Work After Occupational Hand Injuries. Second place goes to Aleksandra Drabik for the work entitled Legal and Practical Conditions of Coordinated Care in Primary Care System in Poland. And the first place goes to Juliana Trembowecka for the work entitled Modern Threats to Eye Health, Dry Eye Syndrome among Students.
Before the last award, I think the best award in conference in Grand Prix, we have also cooperation with Corpus Mind, and we have a competition, internal Instagram competition. And after the awards ceremony awards, please come with us to the office, and we give this award. And now it's time to go to Grand Prix. And the Grand Prix award goes to Aleksandra Openchowska for the presentation of the paper titled Exploring of the Importance of Peripheral Blood Monocytes Subpopulation in the Course of Treatment of Pediatric Patients with Type 1 Diabetes. Please come. Okay, it's our last award. Once again, thank you all for your participants, for your coming. And now I think we should also thank our Dean, and please give some flower, some awards for our Deans, and please a big applause for our Dean.
Sorry, but I must say one sentence. I must say that it's a great pleasure, a great honor for me to cooperate with such wonderful young people as members of Students' Scientific Society of Medical University of Lublin. I think that these flowers belong to all of you. Thank you very much.
And I think it's a time to say that the 11th edition of LIMS is finished. Thank you very much. And please, everyone, go to the common photo. Maybe Kacper, może ustawimy się tam wszyscy, a ty zrobisz...